So my name is Dr. James Lee. I am a doctor in pediatrics. I grew up in California. I lived in the San Francisco Bay Area for the majority of my life. Went to University of California at Berkeley for my undergraduate degree. And then about halfway through, I decided instead of pursuing a career in scientific research, in bench research, I decided that it might be a little bit better if I was around people more often. I decided to go off to medical school instead. In preparation of going to medical school, I obtained a Master's of Science in Physiology and Biochemistry at University of Cincinnati. Then I went off to Miami, to Florida International University for medical school, and then I did my residency up in Massachusetts for pediatrics. It's a number of things. Prior to going off to medical school, I worked as a teacher for a couple of years. I was a fourth and fifth grade math and science teacher, actually. And it was there that I really discovered that I enjoyed working with children. There's just something about children and the way their faces lit up when you're teaching them a new concept that really appealed to me. When I was off in medical school and studying, that kind of got placed on the shelf a little bit. But one of the things they have you do in medical school as a third year and fourth year medical student is you rotate through your various core rotations, so internal medicine, surgery, and whatnot. And I was actually getting a little bit worried and anxious over the fact that I wasn't finding anything that really just gelled with me. Could see myself doing some of the subspecialties, but it just really wasn't fully fitting well until on the back half of my rotations, I rotated through pediatrics, and within about 2 days, I realized, nope, these people are my people. The people I'm working with, the people that I'm treating, these are my people, and that's where that love for working with children was rediscovered, essentially. And so that's how I was inspired to go off into pediatrics. These days, I do a little bit of everything. My roles include helping out with the intakes for our expert search process and our expert search team. My primary role is to function as a case reviewer for pediatric cases at Expert Institute. And so what a lot of attorneys will do is they'll send me their pediatric cases for review. My day-to-day primarily revolves around reviewing these cases, taking my notes, coming to an idea as to what are the both medical and legal issues surrounding a particular case, then discussing them. Usually my discussions run about 30 minutes to an hour or so with various attorneys on these cases. And then somewhere in the middle, if I have time, I'm also helping out with the expert search process as well. A case clinic is what we call our case review product, where I'm taking in the medical records associated with the case. I also sometimes will speak with an attorney to get a better sense as to what are some of the issues that they're looking at when they receive the case. And then I'm going through the records and I'm trying to see what happened. Now, being in pediatrics and medical malpractice, a lot of times these are cases where children have had poor outcomes. And a lot of times what I find in pediatrics, which is particularly unique, is getting the medical legal aspect of it is fine, but what a lot of people run into is the parental need just for answers to figure out what happened, what went wrong, or did anything go wrong. If nothing could have been done, that's also an answer that a lot of people are looking for. And so a lot of times I'm going through the cases, I'm looking at medical records, and I'm making notes of what the disease was. I'm making notes of what are some things that various physicians are thinking at various points of this child's care. And then at the end, I kind of sum it up and I'm reviewing it through the lens of standard of care, causation, and damage issues. And then I prepare my notes, and eventually we discuss. And we talk about what happened. We talk about whether or not this is the case. But my interest, more than anything else, working in pediatrics and being around parents a lot, my interest is, regardless of whether it is or isn't a case, I want to make sure that all attorneys are as familiar with the case as I am, and they feel as empowered as possible to fully discuss the case with the families, so that everybody is on the same page and we can come to a decent idea as to what to do next with the case. In my experience, what attorneys find the most valuable is that, you can get a yes or a no from anybody, and you can get it fairly quickly. What sets us apart from other reviewers, and what attorneys have repeatedly told me is most valuable, is the fact that we bring them along for the ride, so to speak. I'm essentially acting as a tour guide throughout the entire process, and I'm explaining, this is how the child came in, this is what people are thinking at this point in time, this is why they obtained these labs. And I do this on a point-by-point basis, hitting all of the critical points within a child's care. And so at the end of the case clinic process, the what is something everybody will get. The whys and the hows, on the other hand, that's what really matters, and that's what really sets us apart from other people, in my mind. Because at the end of the case clinic, not only will you understand really what I think of the case, whether I think this will be a strong or a relatively weak case, but you understand how and why, and you'll feel very empowered to go back to the family and explain exactly what happened, and you'll be positioned to counsel your client as a result. The cases I tend to see fall within general categories or archetypes. So one of the most common cases I get are pediatric emergency room cases / pediatric infection cases. So these are cases where typically children brought to the ER, they were first evaluated, they were diagnosed probably with some viral illness because that's the most common type of infection that occurs in children. They were then sent home, and then 24, 48, 72 hours later, something bad happens. And the question is whether or not somebody missed it. So that's probably one of the more common types. The other two that I get fairly often are birth injury cases. And this I do in conjunction with our OB/GYN physician, Dr. Jonathan Kubik, where this is a case where pregnant mothers are presenting to the hospital for labor and delivery, and for whatever reason the labor and delivery process didn't really go as well as planned. Now, our OB/GYN, Dr. Kubik, will review the labor management, but where I come in a lot is the baby is then presented, resuscitated, and then subsequently usually brought off to the neonatal ICU for ongoing management. Does the baby's course play out within what we expect for a perinatal birth injury? And so that's oftentimes where I get consulted as well. we've been doing this for close to 4 years now, I believe. We've done hundreds of these cases together, and where our joint case clinics kind of sell themselves apart is that Dr. Kubik and I are regularly in communication with each other throughout the analysis process. Um, and so we do find that this close collaboration throughout the entire process allows for a much better insight rather than if an attorney was going to get an OB and then a neonatologist to review separately. So that's the second type. And the last type that I'm getting a lot these days, due to recent events, are formula cases, baby formula cases. So there's two that are out there. There's the baby formula cases that with respect to neck, and then more recently there are the baby formula cases with respect to the bacterial contamination out of Abbott in Sturgis, Michigan. So these are pretty much the most common cases I get these days. This one, it was a little bit off the beaten path for me personally. The case was in of itself relatively simple. It was a 2-year-old girl who presented to the ER complaints of vomiting, runny nose, cough, congestion, diagnosed with a viral illness, and then sent home. And then presented something like about 24 to 48 hours later, and had very, very critical phosphate deficiency. Now, the way the child presented was because the child started having seizures at home. They controlled the seizures, worked up the seizures in the ER, found that the child's phosphate level was critically low, and they were starting to replenish the phosphate when the child unfortunately coded and died. Now, the legal question here was whether or not that could or and should have been diagnosed at the first ER visit. Went through the records. It was unfortunate, but there really wasn't much of an indication to work the child up for hypophosphatemia. So the legal aspect for this case was relatively straightforward. But then as I was continuing to discuss the case with the attorney said, yeah, mom is just really kind of grasping for answers as to how her child died. She still doesn't really know, and she has a twin sister. And I said, I'm sorry, did you say mom doesn't know and in the same sense tell me that there's a twin? And the attorney looked at me and asked, well, yeah, what's the significance of that? And I said, well, generally speaking, you get to this sort of an issue through genetic means. There's a strong likelihood here, certainly one that if this family was were my patient, I'd say we should probably get the twin tested, or at least have a discussion with the geneticist and with an endocrinologist as to whether or not the twin should be tested for hypophosphatemia. And so, at my strong recommendation, the attorney reached back out to the family, and the family had said, "Oh, thank you so much for telling me this because my other daughter hasn't really been doing well. They're not entirely sure what or why." The family had moved to a whole other state after the passing of their first child, and none of the medical doctors were really sure what's going on. So we were actually able to provide one of the key pieces of the family history to start the workup for the surviving twin. And my hope is that that they're well on their way to helping the surviving twin grow and thrive. So that was a really, really unique circumstance for the case clinic that I don't often get to do. the way the cases are formulated, it's a investigation as to whether or not in the specific demographic of premature of or predominantly premature infants, there is this possibility of this disease called necrotizing enterocolitis, or NEC. We just call it NEC for short. NEC has some associations with formula feedings, but it is particularly nuanced how this all plays out. And so a lot of what I would recommend attorneys do when they're looking at this is the science is not as clear cut as one might think, and a lot of times neither are the actual cases that you look into. There are a lot of risk factors for necrotizing enterocolitis, and one thing that I strongly recommend is to reach out to a neonatologist to review each individual case for an analysis on how many risk factors are already present for NEC. The reason being that although a good majority of these infants do receive some formula product at one point or time in the neonatal ICU, a lot of times there are a lot of other risk factors predominating over the risk of formula feeds. And so it's one of those things where when I've been reviewing these cases, what I've been finding is the unfortunate surprise of, well, either this child's extremely premature or this child was dealing with all of these other medical complications. In this setting, formula feeds may not be contributing nearly as much as one might think towards the development of NEC. It gets nuanced and gets tricky pretty quickly, has been my experience. Pediatrics is very, very different from adult medicine. That's, probably the first thing that a pediatrics resident kind of learns on day one, is that kids are not just tiny adults. The diseases that hits kids is very different. The way it's managed is very, very different. The way we track these diseases and monitor for these diseases is very different. And so a lot of times, if you're having an adult provider review these cases, it looks very, very different from how they would do it themselves. So that's why, for starters, I would strongly recommend getting a pediatrician to review pediatric cases. Now, as for what we do, and why I think we set ourselves apart from just about every other reviewer out there, it's because we'll take the time, we'll review this, and we will make sure that you understand everything about the case from front to back. And we'll make sure that with the level of thoroughness and depth that we review it, that it is all conveyed, and you understand it all at the end. And when you do, I find that attorneys generally are able to do two things better. One, they're better able to make informed decisions about whether or not they want to proceed and continue to pursue the case, or if they decide to drop the case, they can feel much more assured that it was the correct decision for them. If they do decide to pursue the case, they are much more informed about where are some potential pitfalls, because we do also do an analysis as to what are some likely defense positions that the defendants might decide to take, and we can, to a reasonable degree, even start predicting what are some decent legal battle lines that are going to be drawn with regards to these cases. So that's kind of part one. Part two, with regards to pediatric cases, I have found that a lot of times families are much more interested in figuring out what happened versus how do I win a case. And when it comes to, a parent who has lost their child, the desire for answers is almost universal in every single one of the cases that I review. And so what I want to do and what I want to make sure is that, I was a teacher before I was even a doctor. The human element sometimes gets lost in all of this. And how I want to make sure, when I review these cases, is we bring that human element back into everything. It's why I decided to leave clinical medicine, is because the human element was starting to become a little bit lacking, in my opinion. And I want to make sure that whatever way possible, we at least do provide answers, and we at least try our best to figure out what happened and to empower whoever is working with the families to provide a sense of closure and a sense of proceeding forward and figuring and bringing all of this to a close, whether it's through litigation or just answering the question, why did my child die? Our website is available. We'll try our best to work with anybody and everybody, particularly for pediatric cases. I'm someone that regularly just says, hey, look, I just want to make sure that we get to the bottom of things. I'm not somebody that places an overly high emphasis on things like, how do we make sure that, the cases are compact enough so that it's tidily reviewed. Get me whatever you have. We'll find a way to make it work. If you ever want to speak and bring me in on a consultation, be more than happy to work with you guys. At the end of the day, my only goal is to make sure that we get these cases reviewed accurately and correctly, and to make things right whenever we can. My email address is my first name, James, at expertinstitute.com. And, feel free to reach out if you guys have any pediatric cases or any pediatric questions.